Welcome to Stemming the Diabetes Epidemic, Strategies to Improve Prevention and Treatment, presented by Albert Einstein College of Medicine of Yeshiva University at Diabetes Series Live. Today is the first segment in this four-part series and is titled Improving Diabetes Care, Rationale and Initial Strategies with Dr. Martin Abrahamson and Dr. Mark Schutta. My name is Dr. Richard Beaser, and I'm Associate Clinical Professor of Medicine at Harvard Medical School and Chair of the Continuing Medical Education Committee at Joslin Diabetes Center. I'm pleased to serve as Activity Director for this important educational series. Activities on Diabetes Series Live are interactive, allowing us to take your questions in real time throughout this presentation. We encourage you to enter questions at any time in the box located in the lower left-hand side of your screen. I'd now like to introduce our presenters, Dr. Martin Abrahamson and Dr. Mark Schutta. Dr. Abrahamson is Associate Professor of Medicine at Harvard Medical School. In addition, he's Senior Vice President for Medical Affairs at the Joslin Diabetes Center.
Good afternoon. Pleasure to be here.
Dr. Schutta is G. Clayton Kyle Associate Professor of Medicine at the University of Pennsylvania School of Medicine. He's also Medical Director of Penn Rodava Diabetes Center. Martin, thank you for joining us today.
Happy to be here.
Let's get started. Anyone who reads the lay press, let alone the medical literature, is aware that there's an epidemic of diabetes, the cardiometabolic risk factors, and the resulting cardiovascular disease. Health and economic impacts of this epidemic are significant. Blunting this impact requires a societal effort of significant proportion. But the healthcare delivery community can play an important leadership role. Each of us can improve our skills to identify people at risk and initiate early interventions targeting lifestyle improvements. Once diabetes is diagnosed, we can similarly focus on lifestyle modifications as part of the initial therapeutic interventions. Let today's overview on the identification of at-risk people and initiation of early lifestyle interventions stimulate your thinking about areas which you could improve upon in your own practice, and consider seeking further educational opportunities to help you accomplish this goal. Martin, perhaps we should start with you and open up our discussion by outlining the scope of this significant epidemic.
Sure. Thanks for inviting me to be part of this discussion today, Rich. Diabetes today in the United States is really an epidemic and has reached epidemic proportions. 29 million people, or just over 8% of the population, have this disease. And we see higher rates in certain ethnic minority groups such as Hispanic Americans, Asian Americans, African Americans. About a quarter of the people with diabetes are actually undiagnosed, which is unfortunate. And we'll say a little bit more about that later. The number of people with diabetes is growing by more than 1 million per year, and this is a disease that is associated with major mortality, morbidity, and huge cost. The direct and indirect cost of managing people with diabetes in this country reached $245 billion just a couple of years ago, and is projected to continue to increase, consuming about 1 in 10 US healthcare dollars. And of course, if we have 30 million people almost with diabetes, there's more than 80 million people at risk for the development of diabetes. It's also a problem in the rest of the world. Today there are about 382 million people with diabetes, and we're seeing a huge increase in the prevalence in certain parts of the world in particular. In Middle East and North Africa, the prevalence rates are reaching 25% or more. We're seeing an enormous increase in Southeast Asia and the Western Pacific. And the total number of people with diabetes in the world is expected to exceed 500 million in the next 15 years or so. So this is a huge problem. 1 in 12 people in the world today have diabetes. 1 in 2 people in the world actually don't know that they have the disease. So it's 25% don't know it here, but 1 in 2 don't know they have it in the rest of the world. And every 7 seconds, one person dies from diabetes and its complications, which means that by the end of this program, which is nearly an hour long, about 500 people in the world will have died from this disease. In the world today, approximately $1 in $9 is spent in terms of healthcare expenditure is spent managing diabetes.
So clearly the recognition of these people is very important. Can you talk a little bit about that for us?
Sure. What this slide shows for the audience is the tests that we use and the criteria for diagnosing normal, impaired, and diabetes. So the commonest test today is a hemoglobin A1C, which, as everybody knows, is an integrated measurement of glucose over the preceding 3 months. Because this test has become a standardized test, it's a diagnostic test of choice today. At any one time, a hemoglobin A1C of 6.5 or greater is considered diagnostic of diabetes, but must be confirmed on a second occasion. We can also use a fasting glucose. If necessary, we still resort to the 75-gram glucose tolerance test as part of the diagnostic opportunities to confirm a diagnosis of diabetes. And as you can see here, anyone with a fasting glucose of 126 or greater on more than one occasion has diabetes. A 2-hour glucose following a GTT of 200 milligrams per deciliter or greater is diagnostic. And the normal ranges, of course, are shown for everybody to see, but what's important is the impaired glucose or pre-diabetes diagnosis. An A1C of 5.5 to 6.4% is considered pre-diabetes. If the fasting glucose is in the 100 to 125 milligram per deciliter range, we call that impaired fasting glucose. And of course, if the 2-hour glucose following a 75-gram GTT is in the 140 to 199 range, we would call that impaired glucose tolerance.
Martin, what are the specifics about the screening criteria for at-risk people?
So the American Diabetes Association now recommends that anyone over the age of 45 should be screened for diabetes. And if that test is normal, the screen should be repeated every 3 years. There are, however, people at higher risk for the development of diabetes. And the ADA and other organizations have now agreed that anyone who's overweight, and by overweight we mean if you have a BMI of 25 or greater, or if you're Asian American, 23 or greater, and have additional risk factors, you should be screened at an earlier age for diabetes. What are the risk factors? These include people who are inactive, people with first-degree relatives with diabetes, those people who have belong to an ethnic group with a higher prevalence of diabetes, as we said earlier, women who have a history of having delivered large babies weighing more than 9 pounds, or who have been diagnosed in the past with gestational diabetes are at high risk, and we'll hear more about that later. People who are overweight and have hypertension, or an HDL cholesterol that's low, or a triglyceride that's elevated, as being consistent with the metabolic syndrome. Women who have polycystic ovarian syndrome. Anyone who's previously had a hemoglobin A1C of 5.7% or greater, who has previously been diagnosed with impaired glucose tolerance or an impaired fasting glucose, should be tested more frequently. And anyone who has any clinical condition associated with insulin resistance, for example, the presence of acanthosis nigricans, or people who have had a history of cardiovascular disease, are at higher risk for the development of diabetes. So anyone who fulfills these criteria, regardless of age, should be screened for diabetes.
This is clearly a very important population-based problem. Mark, perhaps you can tell us a little bit more about how we would recognize people as they convert from pre-diabetes into diabetes.
Sure, Rich. So right now in the United States of America, as of 2012, actually, 86 million Americans aged greater than 20 years of age have prediabetes. What's really concerning for us is that that number has gone up from 79 million as little as 2 years prior to that in 2010. Right now, less than 8% of U.S. adults with prediabetes are aware that they have that condition. The 5-year conversion rate from prediabetes to type 2 diabetes ranges from 10% to 23%, depending on the diagnostic criteria used. But there are higher risk factors for conversion that we should be aware of. Greater waist circumference, higher BMI are risk factors. Patients who have a higher 2-hour postprandial glucose and those with albuminuria are at higher risk. The testing should be a fasting plasma glucose or A1C. Those are the primary metabolic tests that we use. Only 12.5% of patients with prediabetes could not be identified by